Assalamu alaikum. My name is Boaz Kipkori, roll number DD165005. My task was Benzathine Benzyl Penicillin. The course code is PHL 705. The title is Pharmacy Practice 3. Now, Benzathine Benzyl Penicillin is also known as Benzathine Penicillin G. It was patented in 1950. It is on the World Health Organization's list of essential medicines. The structure involves two benzene rings with the amino groups joining the two. The rational use of benzathine benzyl penicillin is used in strep throat, diphtheria, syphilis, pneumonia, necrotizing enterocolitis, gas gangrene, leptospirosis, cellulitis, tetanus, and ions. It is also used to prevent rheumatic fever. Injection is through the muscle, intramuscular injection. The irrational use of this benzathine benzyl penicillin include use in sterilization of needles and syringes before use, polypharmacy, OTC, over-the-counter medications, underdose or overdose. Adverse reactions. Side effects include allergic reactions, which entail anaphylaxis and pain at the site of injection. When we use to treat syphilis, a reaction known as diarrheic eczema may occur. It is not recommended in those with history of penicillin allergy or those with syphilis involving the nervous system. Use during pregnancy is generally safe. It is in the penicillin and beta-lactam class of medications and works via benzyl penicillin. Mechanisms of action. Benzathine benzyl penicillin is in the class of penicillin medications. It is slowly absorbed into the circulation after IM injection and hydrolyzed to benzyl penicillin in vivo. It is the drug of choice when prolonged low concentration of benzyl penicillin are required and appropriate, allowing prolonged antibiotic action over 2 to 4 weeks after a single IM dose. The alternate drugs for benzathine benzyl penicillin. We have doxycycline, azithromycin, tetracycline, and in case of neurosyphilis, we have ceftriaxone. Brands of penicillin G: Penicillin L, Isojet, Permafen, and Tifasapen. Available dosage forms: injectable suspension, intramuscular injection. There is no oral administration. Case study. Christopher is a 45-year-old man weighing 65 kgs, presents to ED with increasing pain in his left forearm and some decreased range of motion and tenderness in his right shoulder. At his last visit to the ED 5 days ago, he was diagnosed with left upper extremity cellulitis and given a prescription for cephalexin 500 mg PO/TIT for 7 days. Since that time, the patient's car was stolen and inside the car were his antibiotics. As a result, the patient reports today that he has not taken any of his cephalexin doses. In addition to the increased pain and swelling in his left arm, he now also presents with new onset pain in his right shoulder and fever. The SOPs, SOAPs, SOPs. Subjective. The chief complaint is left forearm is swollen and painful, especially when he grips or flexes. Medical history. Left arm cellulitis diagnosed 5 days ago, prescription being cephalexin, but no non-adherence is reported. Type 2 diabetes mellitus DM recently diagnosed. Patient reports non-adherence to prescribed oral hypoglycemic agents. Objective. Age 45 years, gender is male, weight is 65 kilos. Current medication cephalexin. Lab report shows normal range of sodium, hemoglobin, white blood cells, BUN, and glucose, calcium, and chlorine. Assessment. Progressive left arm cellulitis, negative for left upper extremity. New onset pain and tenderness in the right shoulder. Right shoulder fasciitis versus septic joint versus progressing cellulitis. Hyponatremia secondary to hyperglycemia. Uncontrolled type 2 diabetes mellitus, likely secondary to medication non-adherence. Plan. After 5 days of cephalexin therapy, the patient again returns to the ED with progressing left arm cellulitis with continued pain, redness, tenderness, and increased edema. Continued right shoulder pain and tenderness with new onset, right axillary pain and swelling. The left lower extremity pain radiating from the lower back. Upon physical examination, the patient is found to have increased piping edema of the left arm, right scapular fluid collection, and swollen right axillary and adjacent lymphadenopathy. An MRI of the left arm was done to rule out the compartment syndrome. 2 sets of blood cultures were drawn, and orthopedics consulted for potential incision and drainage, I and D, of the left arm cellulitis. Treatment. First line, second line treatments. For first line, we have class 1, 2, 3, and 4. Same for second line if the patient has penicillin allergy. For class 4, we use benzyl penicillin 2.4 grams, 2 to 4 hourly, IV, plus ciprofloxacin 400 mg, PD IV, plus clindamycin 600 mg to 1.2 gram, QDS IV. If allergic to penicillin, we use ciprofloxacin and clindamycin only. The reference include Pharmacotherapy Casebook 8th edition by Terry L. and Julia M. 2. Stevens D.L. Disno A.L. Chambers IHF et al. Practice Guidelines for Diagnosis and Management of Skin and Soft Tissue Infections. That is The website https://adtc.scot.nhs.uk/tpg cellulitis percentage 20 prot.bdf. Thank you so much, ma'am. God bless you.